Chats with Abington Health. I'm Rachel Johnston with Philadelphia Magazine, and I'll be your host for tonight's web chat. This web chat is sponsored by Abington Health in partnership with Philadelphia Magazine. Our topic tonight is lung cancer screening and options for treatment. Throughout tonight's web chat, we hope that you learn who should be screened for lung cancer, the technology available at Abington Health to diagnose lung cancer, and the options for treatment. Tonight we're chatting with Drs. Gaughan and Sundermeyer, who specialize in lung cancer. Dr. Gaughan is a thoracic surgeon, and Dr. Sundermeyer is a medical oncologist, both at Abington Health. Thank you to everyone who've already submitted your questions for tonight's health chat. Before we begin, I'd like to remind you that if you have any questions during the chat, we encourage you to submit your additional questions via the text box right below this video. All questions are kept confidential, so don't be shy. We also encourage you to invite your friends who can log on anytime during the chat. You can do this by sending the link to the Health Chats webpage via Facebook, email, or Twitter. Make sure you stay on until the end because the topics will change based on the questions that come in. All right, Dr. Gaughan and Dr. Sundermeyer, before we get started, can you tell us a little bit about your background and expertise?
Hi, I'm Colleen Gaughan. I'm a native Philadelphian. I did my medical school and surgery residency training at Temple University. I did my first fellowship at the University of Southern California in esophageal surgery and a cardiothoracic surgery fellowship at the University of Miami. I've been in practice now for 5.5 years in the Philadelphia area, and I just joined Abington Health last year.
Hi, I'm Mark Sundermeyer. I'm a medical oncologist, and I'm originally from Missouri, where I went to undergraduate and medical school. I then moved to Philadelphia, where I trained in internal medicine at Temple University, and then did my specialty training at Fox Chase Cancer Center, and I've been at Abington Health now for 8 years.
Great. Well, thank you both so much for joining us. Let's get started. We have some more general questions about lung cancer. So what are some different types of lung cancer?
So lung cancer comes in several different varieties that we usually diagnose based on how they look under the microscope. The most common subtype is called non-small cell lung cancer, and that's made up of groups of adenocarcinoma and squamous cell carcinoma. And then a rarer group is small cell carcinoma, which currently makes up about 15% of lung cancers.
And what are some of the potential symptoms?
Unfortunately, lung cancer doesn't present with a lot of symptoms until usually it's an advanced stage, which is why screening is so important. The most common presenting symptom for any type of lung cancer is a cough, which again in our smoking population tends to be very common and nonspecific. Again, why screening is so important.
And about how early can lung cancer be detected?
So lung cancer is broken down into stages, and with screening tests we can find lung cancer at its earliest stage, stage 1, before symptoms develop. Stage 1 and stage 2 lung cancer is highly curable, and that's the advantage of early screening programs.
Okay, and this question just came in. Is it possible for non-smokers to get lung cancer, and are you more at risk for lung cancer if you're exposed to consistent hand smoke at an early age?
So definitely non-smokers do have a risk of developing lung cancer, but it's about 20 times less than that of someone that does smoke. Secondhand smoke is a very clear risk factor, and you can minimize that through behavior patterns and through local smoking ordinances that prohibit smoking. But it definitely is something to monitor for symptom-wise, but not someone that we would typically screen.
And so what defines a person as a high-risk candidate for lung cancer?
So the current definition of high risk for lung cancer is somebody who has smoked a pack a day for at least 30 years and is above the age of 55. Other things that can make you at higher risk for lung cancer include family history of lung cancer or other exposures.
And is it common for cancer to spread to my lungs if I have had another type of cancer like brain cancer or skin cancer?
So it's unusual for brain cancer to spread outside of that area, but many other cancers like colorectal cancer and breast cancer frequently spread to the lungs through the bloodstream. However, we treat those cancers based on where they came from because that's their behavior pattern, not where they are, and that's not traditional lung cancer in the sense of how we determine to treat it.
Okay, great. And what are some outside resources that we can use to better educate ourselves about lung cancer?
There's several resources that I refer patients to. One that I frequently refer patients to is the Society of Thoracic Surgeons Stop Smoking for Surgery program, which is a smoking cessation program. The Lung Cancer Alliance, which has a lot of really great information on lung cancer screening and treatment. And the American Society of Clinical Oncology has a forum for cancer patients where they can get together and have online chats.
All right, great, thank you. And remember, you guys can submit your questions anytime during the chat in the box below, the submission box. So we're going to move on to screening questions. Who should be screened for lung cancer?
The current recommendations for screening on lung cancer is anybody between the ages of 55 and 74 years of age who has smoked at least 1 pack per day for 30 years and does not currently have any personal history of cancer or has a symptom that is concerning for lung cancer. Those patients would be eligible for a diagnostic test of their lungs rather than just a screening exam.
So we just got this question in live. How often is it suggested that a former smoker who smoked heavily for 43 years undergo an MRI or a CT scan? Like, how often do you suggest someone who is a former smoker heavily for 43 years undergo an MRI or a CT scan?
So the current screening recommendations are for a low-dose CT scan to be performed annually. Our largest trial has the recommendation for at least 3 annual screens, so once a year for 3 years. But the recommendations of the U.S. Preventative Services Task Force is to be screened annually unless you're of an age where you would no longer accept treatment or you have a medical condition that would preclude you from having treatment.
All right, great. And at what age should a screening first take place? And should you be screened more than once over a lifetime?
Screening is recommended to start at the age of 55, and the current recommendation is for a screen once a year with a low-dose CT scan.
And does insurance cover screening?
So at this point, most private insurance companies are covering screening low-dose CAT scans, and we're currently waiting on a final decision from Medicare, but they have given their preliminary approval to provide support to their patients for screening CAT scans as well.
And what kinds of screenings and x-rays are out there, and which are most commonly used?
So for many years, we did clinical studies looking to see if lower specificity studies like chest x-rays would be useful, but unfortunately they didn't really detect adequate lung cancers at an early enough stage for them to be proven to be effective. So currently the only proven modality is the CT scan of the chest low dose, and we're trying to move away from chest x-rays, which are probably not sensitive enough to be considered.
And who would be explaining the screening and x-ray results to me?
In most screening programs, the results are given back to the patient's primary care doctor who ordered the screening study for them. If you have an abnormal finding on your lung cancer screening, at Abington Health, we refer you to one of our lung cancer specialists within 24 to 48 hours.
Okay. And what are my health risks of screening and diagnostic tests? Like, how much radiation will I be exposed to during the scan?
The amount of radiation that's involved in a low-dose CT scan screening for lung cancer is very low. It's slightly more than an annual mammogram.
And remember, everybody watching at home, you can submit your questions anytime during this chat via the submission box below or via Facebook or Twitter. And actually, this one just came in. Since the program was implemented, what are some examples of ways patients have benefited?
So since the program started about 2 years ago, we've had more than 800 patients involved in either our screening program or our lung nodule program. And from those patients that became involved, we've diagnosed 13 early-stage lung cancers, and we found no advanced stage in those screened patients. And that is the purpose of the screening study, is to catch them early when the cure rate is much better than at later stages.
Okay, now we're going to be moving on to the treatment options section of today's web chat. So what are some treatment options for lung cancer?
So treatment for early lung cancer, such as a stage 1 or stage 2, is surgery to remove the lung cancer itself and also the area of the lung that contains the cancer. That is considered the gold standard of therapy. However, that's usually only available to patients who have good functional capacity. That means they get around well, they walk well, they can exercise, and don't have severe COPD or emphysema. Surgery has gone through some advances that we can offer more surgery to more people. However, there are alternatives in treatment for people who may not be eligible for surgery.
And what are those alternate treatment options?
So some of the alternatives are, if you have a more advanced stage lung cancer, like a stage 3 lung cancer where we think lymph nodes are involved in the middle of the chest, we often will start with a course of chemotherapy and radiation to shrink the tumor, which would then allow Dr. Gaughan to consider surgery following that intervention. For more advanced stages, stage 4, where the goals of treatment are to control the cancer, chemotherapies and molecular therapies are the current mainstay. And for those patients with earlier stage tumors that can't undergo surgery, we have focused radiation beams that we use, radio frequency waves that can destroy the tumor, and even cryotherapy where we freeze the tumor.
So I know you just gave us a lot of different treatments, but what are the side effects for each treatment?
So I'll talk about surgery first. Since surgery is the most common treatment for lung cancer, a lot of people who have lung cancer are considering surgery. The most important thing to know about that is that our options for surgery are much more expansive now, and we can do minimally invasive lung cancer surgery. This can have the patient returning to their regular level of functioning within a much shorter period of time than an old-fashioned open surgery. Leaving patients with better overall lung function and less pain. Those would be the main side effects of surgery. The time out that you need to recover from surgery, diminished lung capacity, and pain after a surgery. With the advances that we have now, those are becoming less problems for patients.
And for those patients where upfront surgery isn't the approach that we take initially, treatments like chemotherapy can be quite effective, but they also do have more side effects that affect the whole body, such as hair loss and fatigue. We've gotten much better at controlling nausea over the years, so that's a more minimal problem. And when you combine radiation and chemotherapy, the fatigue can be more problematic. Molecular therapies often have fewer side effects with them, which we use often in stage 4 patients. And treatments like radiofrequency ablation or cryotherapy are actually very well tolerated because they treat such a small area of the body.
And then how do I know if a clinical trial is best for me? What stage of lung cancer is best treated with a clinical trial? And then is clinical trial always a last resort?
So clinical trials are actually available for any stage of cancer. Sometimes those clinical trials are looking at the latest advances in surgery. You know, is it this way or that way? And sometimes the clinical studies are looking at which dose of radiation or which chemotherapy is best, or if we add a new molecular therapy, does it work better? So the clinical is designed to treat anybody at any stage of their illness. And it has to be an area that you feel comfortable with in terms of being assigned to one treatment or another. But they really are appropriate for anyone at any stage of their illness, depending on their interest in it.
Okay, thank you. And what is palliative care, and when should a patient start?
So palliative care is really designed to focus on managing the symptoms of the patient at any stage of their illness. So it's really about treating the side effects of the treatment and improving the patient's quality of life. We really recommend palliative care when anyone is first diagnosed to manage their side effects.
All right, and you can still submit your questions anytime during this chat via the submission box below. We actually just got one in. Would treatments for lung cancer also work for the adrenal gland cancer?
So that's an interesting question. I think that the person submitting the question may be asking about if you have lung cancer that is spread to your adrenal glands, what are your options for therapy? Lung cancer commonly can spread to the brain, the bone, the other parts of the lungs, the liver, and the adrenal gland, which is a small gland at the top of your belly. When you have an adrenal gland tumor, although that would indicate that it's an advanced cancer, a stage 4, if that's the only other site of disease, you could potentially have that removed with surgery and also have the lung cancer itself removed with surgery. There are also chemotherapy regimens that can help with that as well. But considering that it's just one spot that the cancer has spread to, what we call oligometastases, you may still be a candidate for surgery to remove the lung cancer and to have that part also removed.
Okay, great. And this one, just from local Philadelphia, just came through. Does the treatment vary depending on the stage of lung cancer that has been detected?
Right, the treatment can depend on the stage of the lung cancer. In fact, that's one of the first things that we determine when we're treating somebody with lung cancer and making decisions about how they might be best treated. For stages 1 and 2, which are the earliest stages, surgery is considered the first-line therapy, and if someone wasn't a candidate for surgery, then possibly radiofrequency ablation, cryotherapy, or focused radiation.
And if the cancer is more advanced, like a stage 3, that often will require us to shrink the tumor before surgery can be considered, and that would include chemotherapy and radiation, both before and sometimes after as a preventative. And in stage 4, we tend to avoid surgery except in certain circumstances, for example, if just the adrenal gland was involved, and focus on treatments that treat the whole body, like chemotherapy and molecular targeted therapy.
And we just received this question from Montgomery County. What is the correlation between antioxidants and cancer?
So antioxidants, the thought is that by minimizing free radicals, you're getting less genetic damage. And genetic damage is thought to be a large part of how cancer develops. It's not entirely clear that taking an antioxidant will prevent you from getting cancer, but it's certainly part of a lifestyle that's healthy that may minimize your risk of problems as you get older.
Do treatments differ in price, and will my insurance cover my treatment?
So one of the things that we always evaluate before we start any treatment is it covered by your insurance? And we spend a lot of time working with insurance companies to ensure that you don't receive large bills for your treatment. The treatments that we use are all FDA approved for the disease, and almost all insurance companies will cover them in their entirety. We spend a lot of time talking to patients, though. Some of the guidelines now really have pointed out how important it is to know what kind of expenses might be incurred in your treatment and whether you consider that reasonable or not.
And we just received another one from Philadelphia regarding screening, so we're going to kind of jump to that. If someone was in the war and exposed to Agent Orange, should they be screened?
So that's a good question. So that was not specifically addressed in the lung cancer screening studies. But Agent Orange has been associated with a long list of malignancies, and I think you have to take those into account as a special circumstance and look at the surrounding risk factors like tobacco abuse or radon exposure and age and family history, and it certainly might be appropriate to screen someone who doesn't meet the strictest criteria if they're extenuating circumstances.
Okay, great. And back to treatment options. From New Jersey, is a lung transplant an option for lung cancer?
So generally speaking, you need to be 5 years cancer-free before you could be considered for a lung transplant. And that's because of the powerful immunosuppressive medications that are used in order to allow someone to accept their lungs could actually cause the cancer to spread. So with a very few exceptions, a person who's being considered for a lung transplant needs to be cancer-free for 5 years.
Okay, thank you. How do you determine the stage of cancer? This is another question coming in from Twitter from Philadelphia.
So part of the staging workup for anyone diagnosed with lung cancer is often a PET scan, which is a special test in which you're given a dose of labeled sugar that goes to fast-growing cells, and it lights up on the screen where the cancer may be. And in addition, we often will do an MRI of the brain, which will further evaluate other areas where the cancer can spread. So many times, as part of the workup, a patient will undergo a PET scan, an MRI of the brain, and surgical procedures like mediastinoscopy or endobronchial ultrasound to biopsy the lymph nodes to fully stage the patient, because we don't want to take a patient to the operating room for a procedure when the cancer may have already spread beyond the area that can be surgically removed.
Okay, thank you. And from New Jersey, are there any holistic treatments that you recommend?
So holistic treatments are difficult to recommend because of the lack of information about how effective they are. We usually think of them as adjuncts to more proven therapies like surgery and chemotherapy and radiation, and I always try and look at them very closely to make sure they don't have a negative interaction with the treatments that we use. Unfortunately, the literature supporting holistic treatments just isn't as great, and it doesn't make it as easy to recommend those things, but it certainly could be considered in conjunction, if you monitor it very carefully.
Okay, thank you. And from Bucks County, I've heard that you offer genomic testing. What is that?
So one of the big advances in lung cancer right now is determining, are there specific mutations known as driver mutations, meaning they're so important that the cancer can't grow without them. And so we sequence the genome, in this case, very specifically to look for known mutations that we can target. There are genomic sequencing that's happening where they look at the whole genome. That's really on the cutting edge right now and fairly experimental because we can identify mutations that we don't have a drug to target. But at this point, there are at least 3 to 5 known mutations in lung cancer that we can target with medications, and it really has become standard, and it should be offered at any institution. We definitely offer it at Abington Health in order to better focus our treatment and to minimize side effects, as molecular therapy is often better tolerated.
Okay, thank you. What is the difference between a PET scan and a CAT scan?
So a PET scan and a CAT scan are similar in the sense that, at least at Abington, the way we use our PET scans is it's a merger of a PET scan and a CAT scan, so you get 2 tests in one. CAT scans use radiation to make slices of the body, which gives you a very nice picture of the anatomy of the body. And the PET scan, someone is given that labeled sugar that I mentioned that's taken up by fast-growing cells. So you not only see a mass on the scan, but a bright mass on the scan that helps you determine whether something is malignant and hyperactive or benign.
Okay, thank you. Is it safe to exercise during a lung cancer treatment?
We actually encourage our patients to exercise around the time of their treatment and to maintain as much of their normal lifestyle as they can. Especially with minimally invasive surgery, you can return to your regular level of functioning much sooner. I encourage my patients to go out and walk immediately after surgery, in fact, the day of surgery, and sometimes the day of surgery, and definitely the very next day we have them up and walking. And by the time that they're home, they're able to walk around and do many of their normal activities. We want them to get back into their exercise program at about 2 weeks after surgery, no later. And it really does help to maintain not only their health during their recovery from surgery, but also their mental health.
And from a chemotherapy perspective and molecular therapy, fatigue is one of the big side effects of the medications that we use. And the only thing that's actually been shown to minimize fatigue from these treatments is exercise. And many times it's the last thing a patient wants to do is, after they get home from their chemotherapy, get up and be active. But it's really worth it in the long run to keep living a full, active life if you can put in the extra time to keep active.
Wow, that is so interesting. I didn't know that. Can treatments cause other problems such as heart, lung, kidney damage, disease, or fertility problems?
So specifically, chemotherapy is most known for affecting fertility. And in lung cancer, that's less of an issue, as the majority of our patients are diagnosed past their childbearing years. But chemotherapy definitely can stop the ovaries from producing effective eggs. And some of the chemotherapies that we use can affect the heart in terms of the strength of the pumping. Not so much in lung cancer, but in breast cancer and lymphomas, we often use chemotherapy drugs that can affect the cardiac function. Some of the newer molecular agents can have been associated with strokes and heart attacks, and we try very carefully to tailor those treatments to the patients that we think they're the most safe with the lowest risk. But all of these treatments have complications that can affect the function of the rest of the body, and that's why the monitoring during treatment is so intense to minimize that risk.
Wow. Remember, everybody watching, you can submit your questions anytime during this chat via the submission box below. We actually just received one in from Ben Salem. The question is, can over-the-counter drugs impact my chemotherapy?
So, not that we know of. So most over-the-counter medications don't have a direct effect on chemotherapy. When you go to your doctor and receive chemotherapy, it's given into the vein, and the body actually clears it very quickly, often within 24 or 48 hours. The way the chemotherapy works is often by affecting how cells grow and divide. And there aren't any over-the-counter medications that would block that medicine from doing its job. Some of the molecular therapies, like Avastin for lung cancer, can increase your risk of nosebleeds. So if you're taking a lot of ibuprofen or Advil, it might coincide in terms of side effects, but would not stop the treatment from doing its job.
Okay, great. And another question from Westchester. What questions should I ask when deciding where to have surgery? Should I get a second opinion?
There's been a lot of talk about second opinions, especially lately, and there are very standard guidelines for when somebody should receive a lung cancer surgery. Of course, it's always a bit of a judgment call, determining somebody's functional status and making sure that they have enough lung reserve in order to tolerate surgery. I think that you should go to a place where you feel very comfortable with the surgeon, where you feel comfortable asking them the hard questions. How many surgeries have you done? Are you experienced in minimally invasive surgery? What is your own personal mortality rate? And the surgeon, I think, should be prepared to answer those kinds of questions. I think that the most important thing is the level of comfort that you have with your surgeon, your ability to ask questions, and also to make sure that you're in a place where you feel like the continuation of care will be good as well. Where there's enough support from medical oncology and also from radiation oncology to make sure that you're going to get the full breadth of opinion and treatment. Probably the most important thing that I tell my lung cancer patients is that we present our cases in a multidisciplinary forum, that we talk over all of the cases so that everyone can weigh in an opinion. You're not just getting my opinion, you're getting the opinion of my colleagues as well.
That's so good to know. I love that. Are there support groups that I can go to during treatment that will connect me with other patients?
So at Abington Health, we have a full-time social worker that helps with managing our support groups, and we have close relationships with other organizations such as the Breathing Room and Gilda's Club in terms of finding support groups, not only for the patient, but for the patient's family members. And so getting through this whole process requires more than just doctors and nurses. It requires social workers and support agents and nurse navigators, and we have those full options available for our patients who are facing this diagnosis.
Okay, great. And now we're going to go into another section of specific questions that we've received and very specific cases. We actually just received one from Deptford, New Jersey. My mom was diagnosed with cancer. I'm going to the oncologist with her, but what can I do to prepare?
So when you accompany someone to the office visit, your job is to keep track of what's happening during the visit, because as the patient, it's really easy to get overwhelmed with the information and the diagnosis. So you're to help remember the questions that you guys talked about before the visit. What is the stage? What are my options? Are there clinical trials available? What's the best approach for me? But ultimately, it's so hard to remember all the things that we talk about. So sometimes as the person joining in the visit, you got to jot things down so that you can answer those questions later on when you get home, because new patient visits are often an hour long and they're full of information, and it's hard to keep track of all of that.
Okay. Here we have one from Twitter. I stopped smoking regular cigarettes and I'm now using e-cigarettes. Are they safe?
So that's a hard question because e-cigarettes are relatively new on the market. We don't fully know the dangers associated with them. We do think that there's probably a lower level of carcinogens in them based on the way they're developed, but they aren't thought to be totally safe. That they probably are a step in the right direction, though we're still waiting on information determining the risk associated with that.
The important thing to know also about them is that the rate of nicotine poisonings in adults as well as in children has gone up exponentially with the advent of e-cigarettes.
Okay, we have a question from Mount Airy, Pennsylvania. If I am 58 years old and have been smoking for 45 years, what would my cancer screening involve?
So being over the age of 55 and having smoked for more than 30 years, probably a pack a day or more, this person would be a good candidate for a screening program. They would be the perfect candidate for low-dose CT screening, starting with once-a-year imaging, further follow-up studies based on what those studies show. But that is the perfect person. That's the person who's young with a high enough risk factor that we want to find their cancer early, and we want to treat it with surgery when it's an early stage and keep the cure rate as high as possible.
Okay. We have another one. I was a smoker for 20 years off and on. I do not have symptoms. I smoked 1 pack a day when I was younger and maybe 5 cigarettes a day when I hit 25. I'm now 36. Am I at risk?
While I would never say that someone who smokes has absolutely zero risk, it really does depend a little bit on family history and genetics. Your specific amount of smoking is not what is considered to be high risk, and also your age is too young to be considered in the high risk category. So right now, you would not be a candidate for screening. The thing that I would tell you is you've already done the very best thing that you can do for yourself in trying to prevent lung cancer, which is quitting smoking. And I wish you all the luck in trying to continue your abstinence.
Okay. After smoking heavily for about 20 years, I quit in 1983. Should I get a CT scan, or are there any other scans, I guess, that you suggest for this person to receive?
So the thought currently is that if you've quit more than 15 years ago, that you don't meet the strict criteria for the screening programs. And what previous studies have shown is that after 15 years of not smoking, your risk almost approximates that of someone who was not a smoker. Your risk is a little bit higher, but it's still much less than someone who is a current or active smoker or a former smoker within the last 15 years. And that should drop your risk down to close to about 1% or less.
Okay, this is in from Montgomery County. I'm a lung cancer survivor. Are there volunteer opportunities at Abington where I can help other patients?
So at Abington, we do have a robust volunteer program, and many of our former patients, once they're far enough from their diagnosis and not traumatized by coming to the chemotherapy room, can actually be a part of what we do every day there. And there's many ways that you can get involved at Abington Health and be a part of the volunteer program.
Congratulations.
Yeah, that's so inspiring. My mother died from lung cancer and my father from cancer of the mouth. My mother smoked cigarettes and my father smoked cigarettes and cigars. I have never smoked, but should I be screened as a result of being exposed to secondhand smoke?
So at this point, we don't have any firm guidelines on patients who have family histories or documented secondhand smoke exposure. And because there's only one clinical study at this point that has really proven the benefit of screening CT scans, it's hard to know with these special circumstances whether you fall in or outside. But for someone that was a never smoker, I think that CT screening is probably a step too far, and that in that case probably the risks of the procedure with radiation exposure and incidental findings would outweigh the benefits and would not recommend screening in this situation.
Okay, we have one in from King of Prussia. How can I get my sister and mother to quit smoking?
That's a great question. And if there was one way that I could tell you that would work for every single person, believe me, I would do it. We all have loved ones in our family, in our lives, who we really want to quit smoking. Lots of support and encouragement. Try to avoid nagging. I know it's difficult. But you also might want to ask them to have a conversation with their physician. There's new drugs that are available by prescription that are very successful in having people become abstinent from smoking. Not all of them are nicotine replacement therapy, and the success of the smoking cessation programs with medications combined with support are much more successful than trying to quit cold turkey.
Yes, great suggestions. Here's another one. Although I have no symptoms, as a former smoker, I always wonder if my former bad habit will catch up to me. What, if anything, would warrant a lung cancer screening for someone who is asymptomatic? For perspective, I'm 61 years old. I smoked for 30 years, 5 to 6 cigarettes a day, and I quit 15 years ago. Also, I do have a history of breast cancer back in 2007. Does this make me more at risk?
So the smoking history, it sounds like having quit over 15 years ago and having a limited exposure rate in terms of how many cigarettes you've had would meet the traditional criteria for the CT screening program. But you might take into account the fact that you had a breast cancer, and many times if you have breast cancer and you have a lumpectomy, you will be exposed to radiation, which potentially can raise the risk very slightly for lung cancer. So right at the edge of meeting the criteria for CT screening for lung cancer with a second risk factor, you could certainly consider it. And in the absence of symptoms, it's not mandatory, though, based on that information.
Okay, and we have another question in from Cherry Hill, New Jersey. Is smoking marijuana a risk for lung cancer?
So I don't know that we entirely know the answer to that question. There have not been large studies looking at the risk associated with marijuana smoking. The thought is that potentially any drug or inhalation agent may cause some evidence of damage to the lung through the process of smoking itself. And we know that the majority of lung cancer is a consequence of DNA damage due to injury patterns. So I don't think any inhalational smoking of any medication or drug is without risk. That risk may be much smaller for marijuana compared to cigarettes, but I don't think we know the answer to that.
Okay, thanks. 8 years ago, I had a chest x-ray, and the next year, a CAT scan. I have 3 lung nodules, and they have not changed at all. How often should I have these CAT scans?
Some of it depends on the size of the lung nodules and if they've changed at all over time. That's usually how we follow lung nodules. A lung nodule that's small, less than 1 centimeter in size, and has not changed in size for 2 years, can usually stop being followed. However, there are important exceptions to that. That are dependent on specifically what it looks like on the X-ray. There are certain types of nodules which we call ground glass opacities, which need to be followed longer because they still have the potential to turn into a cancer, but do so very slowly. We don't have a good guideline exactly on when to stop following those nodules, so they may need to be followed over the course of several years. It really does depend on the size, the characteristics of the nodule, and whether it's changed over time. So it may be that you need to follow up again with your physician.
Okay. I was treated for stage 1 adenocarcinoma on my right lung in early 2011. My physician wants me to get a PET scan to check on my current lung status. Can you tell me about what I may experience moving forward?
So currently the guidelines for patients that have been diagnosed with a stage 1 lung cancer that's been removed recommend periodic CT screening based on your symptoms and time that's passed. And now it sounds like you're about 4 years out from your diagnosis. The guidelines don't incorporate routine PET scans as part of the follow-up staging process. But certainly up until at least 5 years after your diagnosis, you may undergo CT screening. And if you meet criteria and are within the screening guidelines of having been a former smoker, you might still be recommended to screen after that 5-year window. PET scans are not part of the typical screening that we recommend.
Okay, great. Here's another one from Morristown, New Jersey. I'm a 62-year-old female. Lung cancer has taken my father, 2 brothers, and my nephew. My 80-year-old sister is being put on hospice due to her lung cancer as well. They all were very heavy smokers throughout their lives. I was a smoker as well, but only on occasion until 10 years ago when I quit altogether. I'm scared to get my lungs checked. Any suggestions of where to start and what I could do next to calm my nerves?
So I think that the first step is actually empowering yourself to get the test done because you know that you have risk factors and that you might meet criteria for screening tests. And the fear of getting the test is usually overcome when you have the test done and the results are reassuring. But the beauty of this test is catching the cancer early, and so delaying the test will not serve any advantage. and getting the test done will alleviate the fear. It's taking that first step to start the screening process that will help with the fear after what you've gone through with your family.
The important thing to know about lung cancer screening also is that it's non-invasive. It's a CT scan, commonly performed X-ray, no needles, no sedation, no colon prep, and makes it a lot easier to accept.
Okay, thanks. Screening for lung cancer has traditionally not been recommended due to poor specificity. To false positives and unnecessary interventions and their associated risks. How is the screening test you propose different? And do you envision universal lung cancer screening in the near future, much like colonoscopy for colon cancer? And if so, what kind of test would look like this?
So I think that what's changed from the past is many of the previous studies were done with chest x-rays, which aren't specific, and they were overly sensitive and resulted in people going through a lot of additional testing that they may or may not have needed. And at the end of the day, those studies didn't show that patients lived longer, and that's the ultimate key to which we hold ourselves, is if we're not doing something that's helping people live longer, better lives, we're not accomplishing anything. The current studies, however, have shown with CT screening that people are having their lives saved by this modality. And so you can go through these CT scans and you can find nodules and you can find cancers early and you can reduce the mortality or the risk of death from lung cancer by 20%. And so the difference with this test as compared to other testing modalities is that we really have proven a true benefit in saving lives. And I don't think that screening will ever be universal. The way that screening works best is when you screen an at-risk population. If you send everyone who could potentially get a lung cancer but doesn't have risk factors, the screening tests actually do tend to outweigh the benefits from the risk that they imply. So I don't think we'll ever reach a point where universal lung cancer screening is recommended, but focused screening is effective and recommended.
Interesting, thank you. And everybody watching, remember you can submit your questions during this entire web chat via the submission box below. So we just got another one in from Collegeville, Pennsylvania. Can non-smokers get lung cancer?
They can get lung cancer. Their rate of lung cancer is about 20-fold less than that of someone that smokes, but it does still happen. And those patients are much more prone to have those targeted molecular genetic mutations that we talked about earlier. And so those are the perfect patients. They often have an adenocarcinoma of the lung, for which you can find EGFR mutations or ALK mutations and use targeted, minimally toxic treatments. But there is certainly a risk of developing lung cancer, but much, much less than someone that was a smoker.
Okay, and we have another one in from Twitter. How does my diet affect my risk for lung cancer?
That's a good question. So there have been some studies linking obesity with the development of lung cancer, perhaps through an estrogen-related disorder. But the diet, as far as we know, has not been strongly implicated. And changing your diet has never been shown to reduce your risk of cancer. So at this point, I have to say we have a lack of information about how your dietary intake or change might affect that risk, and probably can be considered a negligible factor at this point for lung cancer development.
Oh, interesting. And here's a really good one from Doylestown, Pennsylvania. Can my blood test during a physical show if I have cancer?
So that's much less likely to be helpful. We know from clinical studies that probably about 15% of patients can have an elevation of their white blood cell count, which is a marker of their immune system when lung cancer develops. Unfortunately, that tends to be a presentation later in lung cancer. And so to date, we have not found a single blood test that was a reliable screening test. And so relying on routine blood testing to find these disorders just isn't recommended at this point. We're always searching for biomarkers. They've looked at breath tests, enzymes that come out in the air, and there may be some potential there. We just haven't yet achieved that as a reliable way of testing.
All right. And I'm going to jump back to screening real fast. We have one in from Mount Laurel, New Jersey. If I'm getting screened for lung cancer, are there certain guidelines I need to follow prior and during the screening?
Most important thing about screening is, aside from meeting the criteria, again, between age 55 and 74, and you must commit to an annual screen. We can't encourage somebody from just one screen to say, okay, you've had one low-dose CT scan and you don't have to worry about lung cancer anymore. If you still are in that high-risk group, we recommend the annual screening. And certainly, any screening program needs to be closely tied to a smoking cessation program. We don't want a screening program to become a false sense of security that allows somebody to keep on smoking. All of our patients who are active smokers and in the lung cancer screening program are referred also to our smoking cessation program.
Okay. And in summary, when we are considering our options for lung cancer screening and options for treatment, what are the most important aspects to consider?
So I think the most important aspect with screening is early detection, early diagnosis, surgical intervention, and a much higher cure rate for those stage 1 and stage 2 cancers. And even in those situations where we don't find the cancer early, to know that there are so many developing therapeutic technologies that we can do a lot more, but I still feel that screening and early detection, finding that stage 1 cancer is our goal, and enrolling in a screening program, if appropriate, is absolutely a great recommendation.
Before the lung cancer, National Lung Cancer Screening Trial, about only 25% of cancers that presented to their physicians were at a stage where they could be potentially cured with surgery. 1 in 4 patients. And we're looking to change those statistics, looking to change the course of lung cancer and lung cancer treatment.
And what are the key takeaways that you would like our viewers to leave with today?
So I think one of them is, finding a physician that you trust and your primary care physician to recommend a screening program when it's important, to really know what your risk factors are and to know that it's never too late to quit smoking and that every year that you've quit smoking, your risk is going to continue to decline. And to follow through with your health provider's recommendations for screening programs and smoking cessation and exercise and healthy diet, and to find a physician that you trust if you are diagnosed with a lung cancer to do your surgery for you, and a medical oncologist and a radiation oncologist that you have faith in their recommendations, and that you think about clinical trials because sometimes they offer good opportunities, and not to be afraid of them because they're not experimental in the sense that we're just trying to get information without the potential for you as a patient to really benefit from them.
All right, Dr. Gaughan, Dr. Sundermeyer, that's all the time we have for today. Thank you so much for being with us and sharing all of your great insights on lung cancer screenings, on options for treatment. If anybody has further questions, you can contact Kelly Pressler at 215-481-LUNG at Abington Health. We want to remind everyone that our next chat is on Thursday, February 19th at 6 p.m. with Dr. Fireman. He'll be educating us on how we can prevent heart disease. You can sign up and ask your questions ahead of time by registering on www.abingtonhealth.org/healthchats. Thanks.